Okay, and I'm letting the students in.
Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We'll be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed.
Good morning, everyone. I'm honored to introduce our mentor for today, Dr. Lodhi. Dr. Lodhi is a general practitioner at the Asquith Doctors Medical Center, and she is affiliated with the Australian Medical Council. Dr. Lodhi is also TeleShadowing's Australian Medical Regional Director, and it is currently 1 a.m. in Australia. And we would like to thank Dr. Lodhi for dedicating her time to help us and teach us in the late hours. Thank you.
Welcome. All right. So should we start?
Yes.
Okay. So good morning, everyone. So as Minahal has already told you about myself, so my name is Dr. Lodhi, and currently I'm residing in Sydney, New South Wales, Australia. Okay. So I have been living here since 2013. When kind of like I started my journey in Australian practice, starting with my examination. So pretty much it's just, I tried to just compile what it has been through since I graduated. So I graduated from Pakistan in 2001. Went to US, stayed there for almost like 2 years. And I tried to, first I thought that why not just go ahead with the US exams, and I just did my part 1, and then somehow we moved back to Pakistan. So in between, I have been like working in family medicine or internal medicine in various countries, like especially in Pakistan, because for the other countries where I have been like Singapore, New Zealand, definitely I need to get their registrations, which was very difficult. So because I was just staying there for a year or 2 years. So when I finally immigrated to Australia in 2013, so I started my kind of like working on my exams towards the registration in Australia. So the pathway was taking a few exams, like the MCQ exam, which is known as the part 1, then the clinical exam, followed by the pesky. Pesky was the exam just getting into the general practice. Okay, and after doing that one, I started working in general practice in 2017. And at the end of the slides, I'll just let you know, as an international medical graduate, what's the pathways, and if some of you guys decide to come into Australia as an international undergrad student to study in Australian universities, what would be the pathway? I just will be sharing some links with you as well at the end.
And Dr. Lodhi, I just want to make sure that to share your screen, just in case.
Oh, well, it's not being shared?
Yes, we can't see right now.
You can see it now or not?
No, not yet.
Okay, sorry. I'll just do it again. Just stopped sharing. Can you see it now?
Yes, we can see it now.
Okay, so just go. Okay, so once, as I said, that once we will just go towards the end of the session, I'll just show you some of the flow diagrams about that, how to get into the Australian pathways. So in the general practice in Australia, once you get into the general practice, you need at least 4 years of experience before finishing your fellowship exams, which is the specialist exams for the general practice. It can be like international experience plus at least 1 year of Australian experience. For myself as an international medical graduate, I had like assessment of my work done overseas equivalent to 3 years, and then I have been working here like since 2013. So I just stepped into doing my fellowship exams, which again was a set of like 3 exams, like the knowledge base exams like AKT and KFP, and then the clinical exam of the clinical exam, which was like, because of the COVID, they did it like it's a remote clinical exam. Like previously it used to be the face-to-face one. So finally I just finished with that one in 2021, and now working as an specialist general practitioner in Australia now. All right, So today, what we will do is that, of course, as I have been informed once I just joined this brilliant program, that we generally go through certain clinical cases or the topics. So that's the upcoming students who are young students willing to get into the medicine. They do get like some idea about medicine in different parts of the world, as well as some of the insight into what's the things we are doing and how we are doing it from day to day. So today I just chose one of very common topic, probably because it's worldwide, it's becoming really common condition, celiac disease. So we'll just go through what are the clinical presentation of the condition, how we are assessing the patient on the basis of the history, then how we diagnose the patient, and then what is the treatment and what is the ongoing monitoring of the patient, because unfortunately celiac disease, just like some of the condition, is a lifelong condition. All right, so that's why the monitoring becomes very important. So we'll just go through a case study. All right, so that's kind of pretty much genuine case. And I have been like, since I have started working, probably 5-6 cases in different ages, but quite common in this age as well. So for today, our patient is a 27-year-old Belinda Edison, who is a primary school teacher. And she presented with complaints of being tired and abdominal discomfort with diarrhea. But there has been a long-term history with recurrent miscarriages in the preceding 3 years, and long-term history of low ferritin levels as well. All right, so her presentation at the time when she presented, so that's the past history of like low ferritin, have been on the iron supplements, recurrent miscarriages, and current presentation after having some food, thinking that probably it's a food poisoning or some viral gastroenteritis with abdominal discomfort, diarrhea. Okay, so initially, of course, apart from taking the history, when we went into the physical examination, there was like no close or the first degree relative for this particular patient with any history of malabsorption syndromes. That's strange. Sometimes it can happen without any family history as well. But when I did the examination, her blood pressure was low, pale skin. Okay, you can expect low blood pressure and pale skin, dry skin, especially when patient is dehydrated with gastroenteritis as well anyways. But because of that preceding history of low iron, and she mentioned that this has been happening for some time, especially diarrhea or sometimes the constipation with abdominal discomfort, uneasiness after having her foods most of the time. So we thought, like, why not we should just go ahead with some initial testing, the first line testing. So on the repeat testing, she was found to be again low on serum ferritin, low blood B12 level. Vitamin D was low, with the TSH being normal as a common cause of the tiredness. So we generally do it. And you know that hypothyroidism can also be the common cause for recurrent miscarriages and tiredness, and you know the bowel disturbances as well. Fasting glucose to be normal. Okay, so after having that one, because the presentation is with suggestive of some malabsorption condition, so we proceeded with the celiac serology. Okay, so when we are doing the celiac serology, we generally check certain antibodies. Okay, so the most common one and the most significant in case of the celiac disease is the tissue transglutaminase and anti-gliadin antibodies. Okay, and there is also another one, the anti-endomycin antibodies. So I didn't mention it here, sorry. So it turned out to be that her antibodies level, which are normally less than 20, was quite high. Okay, and that was kind of like if a patient is presenting with that type of like clinical presentation of malabsorption syndrome, okay, and your celiac serology is high, that is suggestive of celiac disease, but that is never confirmatory for celiac disease. It can just tell us that, yes, probably the patient can have celiac disease, but for the confirmation, we always have to have an endoscopy and a duodenal biopsy to be done. And for that reason, that's the point where a specialist come into play, and we generally, as a general practitioner, refer the patient to the specialist, and generally it's the gastroenterologist, who, after kind of like the initial assessment, do the gastroscopy and then take the duodenal biopsies, having a gross look at the histology, as well as also looking at the histology under microscope after having the biopsy. So that was just the how we proceeded with the initial sort of like the investigations and the case with celiac disease of Belinda. Okay, so what is celiac disease? Basically, so celiac disease is a disorder of small bowel, which is caused by the immune response to ingested wheat related proteins, and these proteins are commonly known as gluten. Okay, and they are present in rye, oat, and barley, and wheat. Okay, so if a person who does have celiac disease keep on ingesting food which is rich in gluten, this ingestion results in ongoing inflammation and the tissue damage of the small intestine. Okay, so as we said that it is an autoimmune disease, so it's basically, you know, that for any of the autoimmune disease, it's always being triggered by certain agents. Like for that one is the gluten. Okay, so if we just look at that one, as I said, especially for Belinda, there was no first degree relative that was having a known condition of malabsorption like celiac disease or any other autoimmune disease. But for most of the patients, there can be a positive family history of celiac disease. Okay, there is 10% higher chances of a person to have celiac disease if there is a first degree relative with their condition. If a person is not having, sometimes people may not be having very evident features, but they do have first degree relative, it is always a recommendation, if someone has been diagnosed in the family with celiac disease, to check the other first degree relative for the genetic susceptibility. And we do check it through the HLA, DQ2 and DQ8. If they are positive, they are very much confirmatory for not the celiac disease, but a tendency of a person or the chances of that person developing celiac disease later in the life. But if these two HLAs are negative, then it is totally exclusive that it will exclude that the person is not susceptible and will now never have this disease. Okay, so that is quite helpful, especially for a person who does have first degree relatives and maybe presenting similarly with some of the conditions. Then we do look for other possible causes of the gastrointestinal disturbances like IBS, irritable bowel syndrome, inflammatory bowel disease, or they can be like SIBO. So other things, we just look for that one. So as you can see in the picture, so that's just the healthy villi on our duodenum. Okay, so after the subsequent exposure of to the gluten, there will be just the atrophy of the villi, which are just the finger-like projections on the inner side of your small intestine, because they are primarily involved with the absorption of the micronutrients like B12, iron. So that particularly is low in these individuals. Okay, so as I just already told you, so there are autoantigens and there is an environmental trigger like gluten, and both of them working together can result in this significant or unique autoimmune disorder. So as we already said, that celiac disease can have presentation at any age. I do have seen many kids to be diagnosed with celiac disease as young as 7 or 8 years old as well. Okay, and some of them can present in their late 40s or late 20s. So it can be any age in which they can present. Especially if the kids are presenting with celiac disease, diarrhea can be the predominant feature. Okay, it's like you can see that it's, if you can just look at the picture. Sorry, let's need to go back. All right. I don't know how to. Okay, so it can be sometimes the kids, most of the time it can be the poor weight gain or failure to thrive for the kids. Okay, but some kids can be obese at the time of the diagnosis as well. Kid can present with a recurrent abdominal pain, which is one of very common presentation in general practice for the kids. And then, as I said, the short stature, failure to thrive, and then we can just screen for the high-risk groups. As I said, that those ones who are with a positive family history, who can just go for the screening, and sometimes it may turn out to be positive as well for them. And surprisingly, for the kids as well, we need the confirmation through the gastrointestinal biopsy, that is the duodenal biopsy, like the adults as well. All right, so when we talk about the clinical presentations in adults, most do not have the diarrhea. Sometimes they do have more as in constipation. And they may have sometimes non-classical features, just like Belinda, like the iron deficiency, either anemia or just the iron deficiency, or they can be the anemia of the chronic disease as well. Unfortunately, because of the micronutrient deficiency, celiac disease just predisposes the individuals to osteoporosis, abdominal pain, sometimes the neurological symptoms and psychiatric symptoms as well. And when you say neurological, it's just because of, again, deficiency of the micronutrients, like the tingling sensations, or pins and needles in the peripheries, and the psychiatric, like they do kind of like cause some sort of like depression. Once even being diagnosed with the celiac disease, sometimes because you are being like so much excluded from the rest of the world because of not that commonly available and a gluten-free food. Now it's getting better, but you just got like being segregated from the other people when you go out to eat, that you may not have that particular food, and then there are very limited choices, so that makes you a bit anxious as well. Infertility, as we said, okay, because of the recurrent miscarriages, and then it can have the effect on the fertility. Recurrent mouth ulcers. One of the presentation, like with most of the gastrointestinal conditions like the inflammatory bowel disease or irritable disease as well, we can have the mouth ulcers. And one of the presentation with celiac disease is also the recurrent mouth ulcers as well. Then, as we said, the vitamin deficiencies, especially vitamin B12 deficiency, okay. One of the presentation, not that common, but still a presentation of the dermatitis herpetiformis, which is the skin rash that just erupts on most of the patients with the celiac disease, can also be seen. And as I said earlier, that sometimes if a family history of other autoimmune diseases are there, we always think about the patient presenting with these clinical features, screening for celiac disease. But you know that most of the autoimmune diseases does have kind of like a chain link with the other medical conditions. So if you're being diagnosed with one autoimmune disease, it increases your tendency to develop other autoimmune diseases as well. And the most common association with celiac disease is for hypothyroidism and type 1 diabetes. And that's why when we will just talk about monitoring, it's really important that we keep on checking and keeping an eye on the patient for the possibility of development of any of these symptoms, because sometimes the symptoms of like micronutrient deficiency and hypothyroidism can be very much overlapping with each other. Okay. As we just spoke about the physical examinations for a patient with celiac disease, as we have seen in Belinda as well. So first of all, the physical examination, you can see pallor due to anemia, hypertension, edema, which is because of the low proteins. They will have low serum albumins because of malabsorption, dermatitis herpetiformis, which is a skin lesions like the rough broken skin, easy bruising of the patients because of the lack of vitamin K, because you know that vitamin K is also being absorbed as a fat-soluble vitamin, so that can also be affected. Peripheral neuropathy, again due to the vitamin deficiency, primarily because of the vitamin B12 and folates, and also having the other, because of the lack of the minerals and the vitamins, patient can also have muscle spasm and the loss of deep tendon reflexes. Okay. So when we are just looking at the, this flow diagram, so you can just see Asymptomatic patients, we just go for the serology. If it's been confirmed, that we can just go ahead with the gastroenterology, and then we can go for the biopsy, and then it will confirm the diagnosis of the celiac disease. Okay, and then it just tells you about the other possible conditions as well. If the person is a high risk population, we can again just go through the evaluation. Just 1 second, I don't know how to. Second. I'm just trying to. Okay. All right. Okay, so then we talk about the lab investigations after your physical examination, as we have seen in the flow diagram as well. So we'll go through the serological testing. So in the serological testing, as we said, anti-myosil antibodies, glided antibodies, and anti-tissue transglutaminase antibodies. When we are looking for these antibodies, at the same time, we can look for the micronutrient deficiencies like iron, B12, folate, and vitamin D. Okay, then we can also, even for the surveillance of these patients or monitoring, we do check them for thyroid disorders and diabetes, but at the initial workup, we can also go for the assessment of these conditions through the serum TSH, fasting glucose levels, and HbA1c for the patient as a screening. So as we said that if these tests, the previous test especially, are we can have the micronutrient deficiencies, but if particularly these antibody tests came back to be positive, suggestive of possible celiac disease, we do go ahead with the referral to the gastroenterologist, who will perform the small intestine biopsy and tissue examination. Okay, and as I showed you in the previous slide, looking for any atrophic changes under the microscope or any gross abnormalities while having an endoscope for the patient as well. And also just looking for other abnormalities that could be the reason for the patient's presentation as well. Regarding the genetic testing, we already talked about the human leukocyte antigen, HLA antigens. Which is kind of like 95% of the patients with the celiac disease have the positive HLA genes, okay, especially DQ8, and the remaining one can have like 30 to 40%. As I said, that it has a high negative predictive value. So if the test is negative, it excludes celiac disease diagnosis with more than 99% confidence, okay. How we will manage celiac disease? So it's really important once we have made the diagnosis, once the patient goes to the gastroenterologist, they did the biopsy, it turned out to be celiac disease, he will tell the patient, okay, you have celiac disease, your histology has confirmed, unfortunately, you need to go with the treatment, and the treatment is a lifelong gluten-free diet, okay. So at that point, the patient is then referred back to us as general practitioners, and then we are the one, we will be managing their chronic conditions. And from time to time, when we do need the ongoing monitoring, which we will talk in a few minutes, the patient will be going back to the gastroenterologist as well for the same procedures. But we as general practitioners, we do just give them some of the, first of all, of course, as I said, that it has a big psychiatric impact, mental health impact on the patient as well after the diagnosis. So of course, the psychological support. In addition to that, we have to provide them with the advice regarding taking care of their nutrient deficiencies, okay? And because it's really difficult to make the choices and to understand what are the dietary choices, because it's a main treatment, for that one, we have to refer the patient to the dietitian who specializes in particularly dealing with the patients with the celiac disease. Okay, so we have already kind of like done the lab work, but the common abnormalities, like I have already told you, iron deficiencies, folate, vitamin B12 deficiency, vitamin D deficiency. They can also be deficient in calcium, zinc, copper. LFTs, you can see sometimes the alkaline phosphatase can be high, okay, and low albumins as well. Parathyroid hormone, sometimes we can go to look for any other secondary bone disease as well. Okay, as I just mentioned in the clinical presentation for the adults, osteoporosis is one of the common risk which is associated with celiac disease, and particularly it's more if the patient is not compliant with their gluten-free diet. So for that reason, we need to go for their baseline DEXA scan, bone densitometry test. So if our DEXA scan is abnormal, then we have to involve another specialist like the endocrinologist for the treatment, and we repeat the test in 3 to 5 years. If it's normal, then we do repeat it again in females at menopause and males at the age of 55. But it all depends like what age the patient has been diagnosed. Normally, celiac disease, it need to be done every 2 years, just to keep an eye that the patient is not developing osteoporosis. Okay. Then, the most important other component for prevention of osteoporosis is making sure that vitamin D and their calcium intake is good, because there is malabsorption, and also they are more predisposed to be having low vitamin D. So we need to make sure that they are either having a sufficient sun exposure, which is abundant in Australia, but anyways, because we got like beautiful weather, but still some time people are not that much keen to be staying in the sun because of the high risk of skin cancers as well, because of high UV. So if they are not willing to be having subsequent sufficient sun exposure, then they can have the vitamin supplements, and making sure that they are having 1000 milligrams of calcium intake a day, in which we just recommend them to have some dietary sources like milk, yogurt, or cheese. And for all these advices, particularly the dietitian plays a very important role in that. Okay, then as we said that as there is 10% higher risk of having celiac disease in first degree relatives, so we do recommend if any of the family member is having any symptoms, should be screened for celiac disease, and the screening should be done only with the antibody testing. We don't have to do the endoscopic examinations or the biopsies to be taken from the small intestine. It is only needed once we have the high antibody levels. Or if someone is not having symptoms, we can just go for genetic testing for them. Okay. We do have like celiac support groups here in Australia, which is the Australian Celiac Support Group. We do recommend patients to join those groups as well, because they do provide with different healthy food options, recipes, gluten-free friendly restaurants, and kind of like sharing their life stories and keep on like encouraging one another. So it's really important. People do find it very helpful. Okay. So what's about the prognosis? So as we spoke about all the symptoms the patient is having with the celiac disease, once the patient has been diagnosed and is on the gluten-free diet, they have noticed there is improvement in their symptoms in almost like few weeks time period. And improvement in symptoms being less number of abdominal discomfort, bloatedness, burping, belching, joint getting better because they do start developing some joint pains as well. Then no more abdominal cramps or abnormal bowel function. Okay, and sometimes some of the individuals, unfortunately, they do not respond to this thing, because then it just goes into further specialty in which they can have non-responsive type of the celiac disease. So symptom-wise, they start improving in few weeks, but if we just look at the laboratory testing, it takes at least 6 to 12 months from gluten-free diet for the patient to have the negative serology. And the negative serology does not mean that they have been cured. It just means that now their guts are no more irritated and there is no more antibodies which are causing more inflammation and damage to their duodenal or small intestinal mucosa. Okay, so as I said, some never recover completely. Unfortunately, that's a very small proportion of the patients who may have non-responsive type of the celiac disease, who just need the specialist treatment. Okay. Monitoring. So when we talk about the monitoring, as I said, it is being associated with certain conditions. So it's very important. Once we have made the diagnosis, we have done all the initial workup for the patient, we have provided them with the advice regarding the micronutrient vitamin replacements, iron replacements, either through the infusion or oral intake. And we have referred them to the dietitian, and they have been on gluten-free diet to do the first follow-up in 3 to 6 months. And the follow-up is the general physical examination, the assessment of their symptom improvement, and then repeating the blood test. Okay. And then from there on, we do it every year. And also doing the testing for, and this testing will include the serological testing for celiac disease, making sure that it's under control, testing for, again, liver functions, iron testing, and also testing for any possibility of developing other conditions like the thyroid disorder, especially the hypothyroidism or type 1 diabetes mellitus. If the patient has shown any of the abnormalities in the blood test, again, we do refer them back to the dietitian because of the inadequate response. Probably the patient is still having some sort of like cross-contamination and has not understood their gluten-free diet. And sometimes, especially if there are symptoms are there or the patient's antibody levels are high. Okay, we do, as I said, we do repeat their mucosal healing, just to look at the mucosal healing. We do refer them back to the gastroenterologist as well to do and follow-up endoscopy and biopsy in 2 years of time. Common gluten-containing foods, which are present in every kind of like meal, most of the places: bread, cakes, cereals, bars, cookies, crackers, pasta, pita bread, pizza, fried or the breaded foods. So, you know, they are all have some sort of like gluten in that, which is kind of like can be the trigger. There are certain foods which are naturally gluten-free diets, okay, and these include fruits, vegetables, nuts, seeds, legumes, dairy, meat, poultry, egg, fish, seafoods. Now, if we just go back, we do have now other options now because as we have seen worldwide, the number of cases with the with the celiac disease is increasing. We do have gluten-free options with the bread, cakes, cookies, pastas, and they do have like the wraps or the pita breads as well, and as well as the gluten-free pizzas as well. So kind of like just to do some of the provision of such food. Okay. Now coming to, so that's pretty much about celiac disease. Okay, so we have just spoke about like how we can be monitoring them, diagnosing them, and taking care of these patients. Now, coming to the next point, like which was if someone wanted to be coming into Australian health system, okay. So we can just see, as you can see, there are a few of the things, like if someone is already a specialist from overseas, then they will be having the specialist pathway, okay? So for the specialist pathway, they need to have the verification. So either you can be either a specialist overseas, or you can be an area of the need specialist, because there are certain specialties in which we do need the specialist, and we are not having here in Australia. So they are the area of need specialist. And there are a few more pathways like the competent authority or the standard pathway. All right. So in terms of this specialist pathway, if you can just excuse me for a second, because I don't know how to, because of the screen, I can't like see the remaining part of my screen. Let me just see if I can bring it down. That's when I'm sharing. The screens are up in the front. All right, so do you know how I can just, because the other people's, like your video is coming in front of me, but I can't like have a good look onto my screen completely. So how I can just made it disappear so that I can see that part of my slides as well. Do you know how to do that?
Yes, I think there's like a small thin rectangle on the top corner of the little video drop down, and you can also drag the videos down like out of your site, because we can't see them on our end, but you can drag them wherever it fits.
That's good. Okay, that's good. All working. Thank you. All right, I can just do that. Sorry, guys. You guys are much more technologically smart than us. Okay. All right, so here you go. So when we go to the specialist pathway, they generally have to send their primary medical degree for the, it's like same for everyone, okay? Whether you're coming through the competent pathway or the standard pathway, and I'll show you what are those pathways, that you need to have your international medical degree to be assessed. Okay, and if you are coming from a non-English speaking country predominantly, then you need to have an English proficiency test, language proficiency testing as well. Okay, so if you just follow that blue line, which is the specialist pathway, they just go because they have verified their degrees, and they just go to the AMC and the college specialist assessment. So they submit their equalization for the assessment, and if they have been assessed to be equivalent to the specialist here in Australia, so they will get the specialist registration. Okay, area of the need one, the same way, they will get the assessment of their degrees. Okay, and then they will have to secure a job offer from that area of need, kind of like the place, and then they will go again for the specialist assessment, and they will be employed at the area of the need, and they will be given the area of the need registration. Okay, for the competent and pathway, again, we have to have the proficiency testing and the verification of the degree, and then we go for the advanced standing certificate, secure a job, then you go for the provisional registration, then you have a hospital supervised practice for 12 months. Then you have the two pathways. Either you can go through the AMC clinical and go for the general registration. So how does it go when you do get like initially an registration with the Australian Medical Council, and you have done your MCQ exam, as you can see up here, and the standard pathway, and then the clinical examination, you can either do it together and go for the job and limited registration, or what you can do is that you can either go for the AMC MCQ and you get the limited registration. So the limited registration or the provisional registration is the one which is just for almost a year. Okay, and you are supposed to be under a supervised work condition, either in the general practice or you can be in the hospital environment as well. Okay, and then after that, once you have qualified for your 12 months, and you will be having a supervisor supervising you for that 12 months with their 3-monthly reporting to the APRA, which is the Australian Health Regulation Practice Agency. And according to that one, if you are satisfying the criteria, then they will give you the general registration, in which you will not need any more supervision, but you will be still required to get it renewed every year. Okay. All right. So now, as I was just talking about the competent pathway, competent authority pathway is for the overseas trained non-specialist, like someone has not done any specialization, but just a graduate from another country. Okay, and they are wanted to be pursuing into their country in Australia. So as you know, that they are either not the specialist, or they can be the general practitioners, like maybe in UK as well. But for part of the UK, we do have like some of the equivalency, and the person who has been working as a general practitioner in UK can work here in Australia as well. This will go for their pathway to get the general registration, which is not the limited or provisional, but just straight to the general registration. They have to who have passed the written examination and have completed training through the board-approved competent authority can apply for assessment under this pathway. So this is about they will just apply, IMGs will go apply directly to the Medical Board of Australia. And then this is a standard pathway, which is just for as an IMG who is coming from an other country, but they have not even done any specialist pathway, or they are not in the competent pathway. They're just graduate maybe, or just have their primary qualification in medicine, as you can see. And that is the MBBS or equivalent of the MD. And they have both, they need to go through that training institution for the Australian Medical Council, okay, and then they can apply for the assessment. Okay, so they will just go through the AMC directly, and they have to go through the exams, which I showed you in the previous slide, AMC, MCQ, that is the CAT exams, and then they clinical exams as well. All right, so specialist pathway, as we already said, they just simply submit for their assessment, and once they have been taken into, then they will be given the equivalent to the specialist degree into that one. Now, that probably will be more relevant to you guys who are in their undergrad and who are willing to come into Australia. Okay, so I just try to fetch some of the information for you guys from one of the, I will share the link. I have just already shared the link up at there. There's Sydney University, University of Sydney, sorry, their kind of like the information booklet. And that's some of the abstract from that one, that for 2022 entry, international applicants must fulfill 2 main requirements, okay? Just give me 1 second. All right, so we just go, so first of all, they should have a satisfactory performance in an eligible bachelor's degree, okay, which is indicated by the GPA. Secondary, they need to have a satisfactory performance in admission test, which is required. That can be GAMSAT, MCAT, or DMT, and DAT, and CDAT as well. So the explanation is up here. You can just see about that one. And as I said, that if someone is coming from US or UK, probably they are primarily the English-speaking countries. But if someone is coming from Pakistan or from other countries like India or Bangladesh, which is not the predominantly the English-speaking countries, then they have to provide with their English requirement, English language requirement as well. And that can be IELTS, or that can be the occupational English training testing as well. Which is done very specific to Australia and New Zealand, okay? And they also have a requirement that they should have biology as a prerequisite. That's just a flow diagram just to see whether you are an international applicant or not. When we talk about, when you will go through this booklet, you will find out that getting into the Australian medical schools is pretty hard, because they do encourage their local students to be coming up here. And when they say that local eligible students, they are either the, as you can see here, are you the Australian citizen, or you are a permanent resident of Australia, or you are a New Zealand citizen, okay? These are all being taken as a local students, okay? If you are not, then you are definitely as an international student, okay? And then with being an international student, you have to satisfy the criteria, which has been just given in this table, okay? All right, okay, all right. So one thing which we have said, just seen in up here, first of all, assessing whether you are an international student or you are eligible for that one, which you have seen up here. Yes, you are an international student if you are not meeting the criteria of the any of the citizenship or these things, okay? And then what you have to do is that you have to see, okay, whether you have completed a bachelor degree of at least 3 years full-time equivalent from a recognized institution, then yes. Did you complete the degree after 1st of January 2012? Yes. And have you completed or will be completing at least 2 years of full-time study or equivalent of your bachelor's degree, passing the honor at the awarded institution? Yes. Then proceed with the next section, which is just up here. All right. So it just tells you that whether you are, so these flow diagrams, as you can see, can help you to understand whether even you are eligible to apply for so it's just one university which I'm just talking about. So they almost follow the same kind of like the pathway. So it will just give you an idea. And if you have any further question, you can always contact me and I'll be more than happy to help you regarding that. Just giving you an idea about as an international student, how much it could be the tuition fees for MBBS in Australia. So these are some of the top universities here in Australia. So like the one which I was just sharing with you is the University of the Sydney flow diagrams, and you can expect at least 80,000 Australian dollars per annum for studying as an international student here in Australia. Okay, it just gives you that, like we were just talking about, like I know that some of the countries, the pathway to getting into medical and coming out of as an MD can take a longer time period. But here in Australia, university medical school, after you have entered for 4 to 6 years, that you will be the intern, which is known as the PGY1. So then you go into PG as a resident to the PGY2. Okay, then you become the senior resident, or you can become the senior registrar. Now there are the two pathways. So here is the general practitioner pathway as well. You can just go from here after 2 years of hospital experience. You can enroll into some college programs and you can just go into the general practice, okay, through the training programs, or you can pursue your career in the specialist registrar, and then which is again 4 years. It is a long path up here as well, and then you become a consultant when you have at the PGY at least 8+ kind of like the years, when you have this much time spent in the different specialties. So that's just kind of like, we'll be giving you just a general idea, okay, about that, how does it goes. So in terms of like as an international medical graduate, what are your requirements? The link is up here, as you can see. And then as an undergrad student, if you wanted to come, I have just added 2 links for you. One is, again, both of them are from the Sydney University, University of Sydney, okay, but they will give you very comprehensive insight into like what are the requirements, what are the things you need to do in order to get into as an international graduate, okay? So if you have any question, and as I said, that if you do have anything for me, which you want me, okay, sorry, there was a few questions. I'll just answer to them in a minute. So as you can see, if you have any further question, especially in terms of like getting into the Australian schools, medical schools, or as an international, I have already told you, then I'll be more than happy to help you or guide you. Okay. So what does stand for the GFD? So it's a gluten-free diet. Sorry. Okay. Okay, no problem at all. So that's all good.
Thank you for your kind advice, Dr. Lodhi. And if anyone has any further questions, they can feel free to ask now, and we'll now begin our Q&A session. So our first question is, which medical institution did you complete your training in Australia, and how long did it take to become a certified general practitioner?
All right, okay. So in terms of like when we are trying to get ourselves registered for, so first of all, as an international medical graduate, you just need to get yourself registered with the Australian Medical Council, okay? So for that one, you do need to, you don't have to go somewhere to get trained, you just need to do certain exams. So one of the exam, which is the first one, is the multiple choice question, which is known as AMCQ1, okay? You just attempt that one. So there are 2 pathways. After finishing your AMC1, either you are lucky enough to secure a job somewhere and you get your limited registration for at least 1 year. And on that limited registration, you still need to go for your part 2 exam, which is the clinical exam, okay, to complete your pathway to getting the Australian medical registration as a complete kind of like the recognized Australian and affiliated with the council. After AMC1, if you do get some job, you still need to go for the AMC Part 2. But if you have already decided that you go part 1, you go part 2, and then after that one, you will be registered with the Australian Medical Council. And now you have 2 pathways once again. You can either go into the hospital, as I just shared some of the slides with you. You can go into the hospital pathway and you start with your 1-year supervised training. That will be general training in all the specialties, especially medicine and surgery and ED, okay? So after this one, after 12 months of your supervised training into that one, you will be given the general registration, and then you can pursue your career into any specialist field, or if you wanted to come into the general practice, then you can just get yourself enrolled in the Royal Australian College of General Physicians. And they have 2 different programs. One is the hospital affiliated one, which is known as AGPT, and the other one is the PAP, in which you just go again through the assessment, 2-year attachment with frequent assessments, and ultimately you will do your final exams, which I just completed with the 2 clinical exams and 2 knowledge-based exams and 1 clinical exam, and then you will be given the fellowship for that. The college, how long it will take, it depends pretty much. I would say that if it's a young graduate, it probably takes from the time of getting yourself registered with the Australian Medical Council up till the point of the fellowship, you can say somewhere 3 to 4 years. But if you do have other commitments, just like me, like the family and all these things, then it can be 3 to 5 years, you can say.
Thank you. Our next question is, given you did give 1 USMLE exam, why did you ultimately choose to pursue medicine in Australia?
All right. Okay. So that's kind of like probably I don't know whether I mentioned this or not, because initially my husband was like doing his master's in the US. So I just joined him in US, and that time we were not sure whether we will be staying in US or moving back to Pakistan or going to another country, because he has been in telecom. So his job is like hopping from one country to the other. So after I did my exam, but he finished his master's and we have to go back to Pakistan. So I wasn't having much opportunity to stay back in the US. So we moved back to Pakistan. And then because now in Australia, we have decided, okay, now we are just staying here, not going anywhere else. So that was predominantly, I would say that was the reason, but it wasn't like I have just chosen Australia over US. It was just because of the moves related to the family.
Thank you. Our next question is, why did you choose to pursue family medicine over other specialties?
Right, that's a good thing. All right, so the thing is that as you have just seen in the flow diagram, getting into any specialty takes a bit longer time. And because of my moves from country to country, and when I finally came to Australia, I wasn't thinking that I should be able to invest that many years into getting into that particular specialty I want to be, because I have to start with my training from the intern level. So in that case, then what was like more convenient for me was going through the exams and getting into a system of family medicine, which has a better kind of like, the balance between the work and the family. So because here in Australia, the general practice is pretty much like, I would say more flexible hours, more convenient. And then kind of like I was like more thinking myself as a generalist rather than going into one specialty. So that's how probably I end up in general practice.
Thank you. Our next question is, what makes the family medicine career challenging?
All right, it's kind of like, it's quite challenging. All right. I am kind of like not sure that we do have like general practice or the primary physicians in USA. I'm not really much sure about that one. I'm sorry, but I do know that kind of like our health system is very much similar to the European health system, because they do have the general practitioners as well. As a general practitioners, we are being called as a generalist. Okay, so it's very challenging that we are the primary contact of any patient coming with any complaint. Okay, and we do think ourselves as a filter. We do think ourselves as a generalist. We are not only kind of like having one specialty. We are having a child walking in through the door, then a patient coming with an gynecological problem, then a psychiatric patient is coming in, and then you can have an orthopedic patient coming in as well. So it's quite challenging that you kind of like keep on switching from patient to patient. So you're not sticking to only one particular thing. So we have been like taking care of people in all the specialty of the medicine, like not to the specialist level, but to the primary level. So I like this kind of like my challenging role into that one.
Thank you. And as you mentioned, you have very flexible hours. Can you discuss more about what your hours are as a general practitioner and how often you're on call?
Being on call, because our general practices are the one, so we do have like the general practices are the one which is not kind of like the individual organizations. Okay, so some of them can have the after hours as well. Some can have only the daytime kind of like the practices. We are open, let's say we are open from 9 till 8 p.m. Okay, 9 a.m. till 8 p.m. But I don't have to strictly be there from 9 till 8. It is quite flexible. If like I do visit nursing homes as well. So Monday, if I'm just visiting the nursing home, I don't have to be there at 9 a.m. It's quite flexible. I can be there at 11 a.m. as well. But as far as my working hours are, like the full-time working hours here is 38 hours per week. So pretty much you can just shift, you can change depending on to your family commitments and everything. So for me, if I'm just working like sometimes a few of the days I'm working like 6 hours of a day. Other day when I'm not having like much commitments at home, I'm working like 8-hour shift as well. And sometimes like normally 7-8 hour shift and alternate weekends as well, because we are open on the weekends, but not all the practices are open on the weekends. As far as your question regarding on call, we don't have the GPs on the call, except the GPs who are working in very rural and remote areas. They do work, there can be only one local hospital. And so for that local hospital, because they, if we talk about the remote areas of Australia, there is severe deficiency of the doctors. Okay, so in that remote areas, generally the general practitioner can be the on-call doctor as well. So for the remote areas, they can be the doctors on call. But for us, like in the tertiary areas, like in the city-based areas, because we do have like hospitals facilities, so the people generally prefer to go to the ED in the odd hours. But otherwise, we are just working as a full-time, providing some of the practices, as I said, after our services as well.
Thank you. And as a follow-up, how would you describe your day-to-day work as a general practitioner?
All right, daily work, look, pretty much it's just based on the appointments for the patients. So they can be either the walk-ins, or they can be the already appointed patients which has made the appointments. And as I said, that it can be from any part of any field of medicine, or even the surgery, who will be walking through your door. So pretty much we do have at the practice, like at a time we do have like 3 practitioners working. So it all depends. Like sometimes we do have the long-term patients with more complex and chronic diseases, so you need to keep on monitoring them. So you kind of like make the subsequent appointments, you set reminders for them, especially for their follow-up blood test and everything. So we just go how they have been like presenting with that.
Thank you. And what is some advice you have for students who are interested in pursuing family medicine or like a general practice?
Just overall, or just in Australia?
You can say overall, just for current students.
All right, okay. Like if I just say pursuing with the family, I believe that family medicine is just the equivalent to that of the general practice up here, because as a family practice, you also work as a generalist. So same goes in the general practice here in Australia as well. So if you particularly have interest, not in any particular field, like someone want to be a surgeon since they start their undergrad or their bachelor's, or someone want to be an orthopedic, they have kind of like their goals they want to pursue. As a journalist, it's kind of like quite challenging field, I would say, and quite rewarding as well, because once you see that you have just come up, like you are kind of like doing a puzzle. All right. So a patient who has presented with a kind of like very vague symptoms. So it's really hard for the specialist. Like we are filtering the patients and then we are assessing, okay, whether this patient need the specialist or not, or I'm okay just to deal with that one. And we have been having 80% of the patients managed by ourselves, rather than putting our pressure onto the specialist or to the hospital system. Okay, so that's kind of like we are doing a major burden sharing on the health system here in Australia, and that's quite rewarding. So I would say that if you do have that passion of like solving puzzles, or so that will be quite a good field for you.
Thank you. And our next question is, what can be the role of preventative medicine when treating diabetes?
All right. Okay. So you do understand that with the diabetes, especially it's the not only the treatment, the medical treatment or the pharmacological treatment, the main part of the diabetes management is the preventive medication as a preventive health as well. We do need to understand, especially in terms of the diabetes, the role of their diet, their exercise, their regular monitoring, their regular checks, their foot checks, their eye checks. So all of these one are very important in terms of like managing a patient's condition and also improving their quality of the life. Although, yes, the pharmacotherapy is really important as well. But apart from the pharmacotherapy, we also have to look for if they are not developing any side effects to the medication and whether they are responding to that as well. So I believe that in the preventive side of managing diabetes, it is equally important as is the pharmacotherapy. And we have been like, as you probably will be aware, that doing the diabetic cycle of care every year, making sure that we have been ticking all the boxes and very closely monitoring the patient, which is like a major kind of like the work for the chronic disease management in general practice.
Thank you. Our next question is, how do you take family history into account given your specialty in family medicine for diseases such as CD or diabetes? Like, for example, would you begin testing for a younger patient with such family history?
All right. Okay. So that's very important. Look, whenever we are having a new patient in our practice, it's very important to have the family history because especially for the cardiovascular disease, coronary artery diseases or diabetes are the conditions which you do know that they do run in the family, like the colon cancer is quite common here. So the family history is very important. Okay. But in order to start with the investigation straight away, once we have the patient, if not having any symptoms, may not be making any sense. So what we do is that we do kind of like do their clinical assessment, and we do have certain assessment criteria for us. So we do assess their cardiovascular risk, we do assess their diabetic risk, and there are certain guidelines here we are using in Australia, like OST risk assessment criteria, and we do go for the cardiovascular risk assessment. We can do the initial baseline investigation for them, like if someone is having a family history of familial hypercholesterolemia, so it makes sense checking their lipid levels. Okay. And then doing the cardiovascular risk assessment, or someone who has a family history of high blood pressure and is presenting with high blood pressure, it is worth checking having the home blood pressure monitoring or having their blood pressure record and checking their cardiovascular risk. Because, and here in Australia, we do have, that the health is under, the health system of the Australia is like, under Medicare. So under the Medicare, they do have given the opportunities for the patients, and they have facilitated the patients and us as well to do the screenings for their chronic diseases. So we do have like 40-year assessment. Once a patient crosses the age of 40, we do go for the diabetic risk assessment, cardiovascular risk assessment, and that does involve doing the testing for their blood testing as well. But if a patient is having a very strong family history of like coronary artery disease or diabetes, we can do this assessment even before the age of 40 as well. So yes, we do take the family history into account, and where appropriate, we do go for the essential investigations as well.
Thank you. Our next question is, how would you personally define quality of life when determining whether it's worth saving a patient? And what are your thoughts on euthanasia and comfort life measures in patients?
All right. Look, maintaining the quality of the life probably is a very important thing, especially if a patient is suffering from the chronic diseases. But as far as euthanasia is concerned, it has not been legalized. It has now been legalized in Victoria, okay, which is one of another state of Australia, but the bill has not been passed here in New South Wales yet. I do know, as I just said, that I have been visiting patients in the nursing home as well. Some of the patients who have been like in a very, I would say, the chronic and vegetative state, probably their family will be more at ease once they see that their loved one have just lived their life and now they are peaceful. Having an end of life is quite peaceful. Probably they would like to go for that one. But personally, if you say, we try to kind of like make the patients as much comfortable as possible, because I have been like doing the palliative care for the patients as well, who are just at the end of their life. And I have seen the families who are kind of like ready and prepared for that one. But the only thing which I have noticed in all these patients and their families is that, especially the families, they just want their loved one to be at peace towards the end of their life. So let's see if the bill passed here in New South Wales as well. So then probably we will be involved as working in the aged care facilities. But so far, what I have seen in Victoria, after this legislation has been passed, people have been giving, especially the families have been giving the positive reviews about having the ability to have the euthanasia.
Thank you, Dr. Lodhi. I'll now pass it off to Hamza to finish our Q&A.
All right.
Thank you, Dr. Lodhi. My name is Hamza, and I'm currently pursuing a joint Bachelor's of Science degree with my Doctor of Osteopathy degree, or DO, at the Lake Erie College of Osteopathic Medicine in Pennsylvania. For the rest of our questions, do you treat OBGYN patients as well, or refer to OBGYN service?
All right, okay. So Hamza, what we actually do, as I said back initially as well, that we do work as a journalist. So when we are working as a journalist, we do expect our patients from the OBG coming to us as well, okay? We do provide the antenatal care to the patients, okay? We do have kind of, some of the general practitioners even do the shared care with the antenatal units in the hospital. Normally, the antenatal care is primarily taken care by the antenatal units of the hospital, but they can't take, as I just already mentioned to Amna as well, that as a journalist, we are trying to share the burden from the hospitals and the specialists. So we do the antenatal care, we do kind of like do the cervical screening testing, or the initial assessment like dysmenorrhea, menorrhagia, and things like that one, or STDs. We have been managing them in the general practice as well. But if it comes to the point, like if a patient is having menorrhagia and comes to the point not responding to the medical treatment and probably need the surgical intervention, that's the point where we do send the patients to the specialist. So we do get them involved when they are needed, but otherwise we try to manage them as much as we can in our general practices.
Thank you for that answer. The next question we have is this. Which electronic medical record, or EMR, is commonly used in family practice and hospital settings in Australia?
All right, okay. So we kind of like use in the general practice, we'd use the best practice and the medical director. They are the two of the most popular softwares we have been using. Like currently in my practice, we're using the best practice, which is more commonly being used in the general practices. In the hospital, I believe they are using the medical director, and all of this system is kind of like centrally linked through my health records, which is they have just started from last like 2 to 3 years ago. They just made it like a centralized portal to have the medical information being shared, but it's only totally patients' consent. If they want it to be centralized, they do. If they don't want to, they can just deny to have that on the central portal. But it's quite helpful. Like the patient has been discharged maybe in Queensland. That's what discussions again coming to us in New South Wales. It's quite easy. You can go to the health record at the central system, and then you can review their discharge summary or the previous history and everything, and the medications, investigations, and everything.
All right, thank you very much for that. I think our next few questions will be about COVID-19. The first question is, how has the COVID-19 response been like in Australia? What has your experience been treating any patients with COVID-19?
All right, okay. Look, being in a geographical area where we are, we have been the one who was kind of like the very late hit of COVID-19, to be very honest, because we got ourselves isolated from the rest of the world. But currently we had a very bad pandemic in 2021, starting from June, when we have the Delta variant up here. As far as treating the patients with the COVID-19 in the general practice, unfortunately, we were not being like that much actively involved in managing the patients because they were primarily being managed through the Department of the Health and the hospitals. Okay, but we, in terms of like screening, testing, vaccinations, general practice has been very actively involved, and we have done like currently we have at least 95% double dosed all the population in New South Wales, and the rest of the states are picking up as well. But in terms of managing or treating the patients in the general practice, we haven't. But what we have done is that, as I said, that if someone is having very mild symptoms and they are being managed at home, we can have their telephone consultations with them, monitoring them, but they have still been primarily being monitored through the Department of Health.
Thank you for that answer. Related to that, how do you stay up to date on new research for novel treatments of COVID-19 or other cases you regularly see in the ER?
Sorry, can you just repeat, Hamza?
How do you stay up to date on new research for novel treatments of COVID-19 or other cases you regularly see?
All right. Okay. So look, it's pretty good since we are in the general practice and we are affiliated with the Royal Australian College of General Practice. So we do get like daily email from our GP. Like we do have a newsletter kind of like thing coming every morning. Okay, with all the current things going on in the medical field. Then we do have like monthly release of checks, which is through the Royal Australian College of General Practitioners, once again, discussing very common presentations and their managements. Then we do have kind of like the articles, HGP articles being published every 3 months, delivered to the GPs. Then we do have all these webinars and the sessions which keep on like popping up on your email, like at least literally there has been like 8 to 10 emails every day just to update you on different kind of like the upcoming advancement, not only in COVID, but all the other fields as well.
Thank you for that answer. Have you seen patients who receive COVID vaccine and still get COVID pneumonia?
Yes, there has been. In fact, we have seen few of the patients from our practice who have been vaccinated with the double doses and still contracting the COVID infection. And most of them were like the healthcare professionals, like working in the COVID clinics or the COVID wards. After the vaccination, they have definitely contracted the infection as we were giving the vaccination to the people, and we were telling them that, look, it's not 100% protective, okay, but you still get the infection. And that has actually proven right. The infection wasn't that severe. The patient has very mild symptoms of cold and flu, and they were pretty much being managed in their homes, in the isolation, but they maintained their vitals. So none of them need to be going to the hospital or any ICU admission. So definitely we have kind of like not a lot of patients in our practice, just a couple, which we have seen in this regard.
And a question that a lot of people probably have is this one: is COVID-19 lung damage reversible?
All right. Look, as I said, like so far, what we have seen in our general practice, even the patients who have COVID previously and now they have recovered, some of them, I was just talking to a patient who had COVID in 2020, and he presented like a few weeks ago for some of his general scripts, repeat scripts. What he was actually mentioning to me was like, since that COVID recovery, he has never found himself to be back to his health, what it was before. Look, depending on to the, is one of the thing the COVID virus was doing was the causing the lung fibrosis, okay? And all of us know that sometimes the fibrosis is very hard to be reverted back, okay? So that means that your lung has been fibrosed, it's been hardened. But to be very honest, in order to give you the more accurate response to that one, probably that will be the pulmonary specialist or respiratory specialist. But what we have seen in the general practice for a few of the patients who have presented back to us after recovering from the COVID, they have mentioned their low levels of energy, easy fatigability, tiredness, which could be the post-viral effect of the medication as well, post-viral effect of the COVID infections as well. But yes, you know, as we are studying, as we are dealing with pandemic, probably we will come up to more information in this regard.
Thank you for that answer. Our final COVID-related question we have is: have you seen COVID cases in the pediatric age group, and usually which age group presents the most severe symptoms?
So as I just said that we have been like pretty much in investigating the patients presenting with the signs and symptoms of COVID for the possible COVID infection. And for those one, we have been like, especially the kids who are going to the childcare. So that can be a child from 2 years old or up to like 5 years old. And then the school kids from 6 years onward. We do have been testing them, but touch wood, none of them came back to be positive in our practice with the COVID. But we do have reported cases of pediatric COVID positive cases, and as young, if you say they were as young as the primary school kids and the primary school like year 2 or 3 kids, but none of them fortunately had severe signs symptoms of the infection and no mortality associated with that one. So which was kind of like quite reassuring, because still we are in Australia, we haven't like decided on giving the vaccination to the kids less than 12 years of age, which we are hoping to be coming soon. Once the trials, overseas trials has been done, probably we will be following US and UK. Yeah, once it will come, probably it will be more safe from parental perspective and as well as for us as well.
Thank you for that answer. There's 2 more questions that we have left. The first one is: have you encountered a high prevalence of skin cancers in the Australian population? If so, how could it be prevented?
Skin cancer?
Yes, skin cancers.
Okay, so as you might be aware, skin cancer is really prevalent here in Australia because of very high UV index. So the thing is that among that one, we definitely have been having, most of the patients here are having annual skin check, especially if they have their childhood excessive sun exposure. And most of our general practitioners, they do kind of like train in skin checks and skin conditions, especially managing the skin malignancies. So with the annual skin checks, if there are any suspicious lesions, of course, they are being biopsied. And if anything comes up to be positive, of course, they are managed according to that one, like the wider excisions or any specialist intervention. But in terms of like prevention, we do have like a very, everywhere, if you go to the schools, to the childcare, to any parks, to the beach, we do have an extensive education for the patients for being sun smart, like slip slop and kind of like everything with the sunblock, with the using of their clothing, with their sun hats, with their sunglasses. So we are kind of like educating, and starting from the preschools, the kids are being educated regarding that, especially during the summer times, because in summers our UV index can go up to 10 or even more, which is quite damaging. Yeah.
Thank you very much. And this is going to be our last question.
Mhm.
How do you manage your work-life balance?
All right. Okay. So as I just I was telling before to one of the question for Amna as well, when she said that why you chose general practice. So managing the work balance is quite good in general practice because your working hours are quite flexible. You can just make the adjustment according to your home life and your social life as well. So I try to kind of like not having, I would like to enjoy my time with the family and the friends as well. So I do kind of like keep my working hours not like out of control. I'm not working every day. So I do have like few days off in my weekdays as well, which I do use for my household chores or my visiting my friends or spending some time with the family. So kind of like it's pretty manageable working as a general practitioner here in Australia, and which I'm enjoying about this field.
Right, thank you very much for answering all of our questions, Dr. Lodhi. These are all of our questions.
Thank you so much.
Thank you very much, Dr. Lodhi. We truly appreciate you taking the time to answer all of our questions. This was a greatly informative learning session for all of us, and I love everyone to please give a warm thank you to Dr. Lodhi, our TeleShadowing Medical Director, in the chat box for his incredibly informative session. Thank you.
You're welcome.
And actually, if students here would like to learn more about our team, feel free to check out our website here as well with our other TeleShadowing Medical Directors and the student team.
All right. Nice talking to you guys, and hopefully it has been a bit helpful. As I said, anyone who would like to have any questions or anything can let me know either through the TeleShadowing, or you can just contact probably some of your student directors as well, who can just direct it to me. All right.
Thank you.
You're welcome. Take care. Have a good morning. And probably I'll just have some sleep. Yeah, it's kind of like very early morning at my side too. It's just 2:20. So probably will have some sleep now. All right. But I'm feeling quite fresh. It just feels like I'm here with you guys in US as well, just in the early morning time. Thank you so much. Really nice talking to you, all of you guys. Very best of luck to you as well. All right.
Thank you.
Take care. Bye. Allah Hafiz. Bye.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live, and the deadline for future quizzes have been extended to 1 week after each session. Again, you'll need a 70% or higher to pass and receive certification, and it's being sent in the chat right now. Don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link that's being sent in the chat now. Now onto our future session dates. These dates will also be posted throughout our social media, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday, on November 27th at 10 a.m. Eastern Standard Time, with our Canadian Medical Director mentoring us in pediatrics. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.